Okay. All right, my name is Adolfo Diaz Perez. I am working at the Hospital del Mar in Barcelona, Spain, at the Institute of Medical Investigation and at the hospital. And also I work for the Autonomous University of Barcelona. I have been involved for many years in the field. And this, statistically speaking, means that since there is a very narrow correlation between years of experience and age, is that I am already a little bit, so to speak, mature. Okay, but the topic for today will be teriparatide and hip fracture, and I would like to thank Dr. Lewicki for inviting me because it's a topic that I believe is important and relevant for the clinical practice. These are my disclosures. Take a moment to read through it. And the clinical question I will try to answer today is if teriparatide is efficacious in the reduction of the risk of hip fracture. Accordingly, the objective of the review will be the analysis of the efficacy of the drug for this particular fracture. We know that teriparatide is a strong bone anabolic that induces a quite impressive bone formation as demonstrated, for example, in this microscope picture where you see that most of the bone surfaces are labeled by tetracycline and an important portion by double labels, showing that the drug promotes in a very strong way bone formation. And also, we know that there are several effects of teriparatide on bone quality. Teriparatide improves bone microarchitecture, reduces the apoptosis of the osteocytes, as well as the microdamage of the bone tissue, and reduces as well the collagen crystallinity and cross-linking. The final result of all these effects is a net increase in bone strength. The original pivotal trial for the approval of the drug was published 20 years ago by Robert Neer et al. At the New England. And this pivotal trial, what demonstrated was a strong reduction in vertebral fracture risk, but with respect to non-vertebral fractures, this was the result. There was a significant reduction versus placebo in the two tested doses of teriparatide, 20 and 40 micrograms. That was quite nice, but since the trial was stopped too early because of some safety concern, and the mean average of the duration of the treatment was 20 months, there was not enough power for showing any effect on the risk of hip fractures. A few years later, this meta-analysis trying to gain statistical power was published by Murat et al. And in this meta-analysis was demonstrated on terms of hip fracture reduction, a nice reduction of the risk of hip fracture by the use of teriparatide. However, in these forest plots, it's quite clear that the confidence interval overlaps the neutral effect line, and this made the results non-significant statistically speaking. 1 year later, another group, and I was involved in that particular meta-analysis, tried to address exactly the same question, and again, there was a marked reduction in the risk, but the confidence interval overlaps the unit. And there was therefore no demonstration of the significant effect of teriparatide on the risk of hip fracture. Meanwhile, several observational studies were published, and in 2018, Bente, Langhal, and others summarize 4 of these prospective observational studies in this publication in Bone, trying to come up with a summary result of this effectiveness of teriparatide on fracture, and in particular on fracture of the hip. And here you see the graph with the summary of the results. And on the right, we can see that compared with what could be the baseline risk, in other words, the risk of fracture during the first 6 months of exposure to the drug, with the risk after 6 months of treatment, there was a strong and significant, in this case, a statistically significant reduction in the risk of the hip fracture in the patients that were receiving the drug for more than 6 months. Therefore, there was a suggestion that possibly what we had was a problem of limited power to demonstrate the effect of teriparatide on hip fracture. And this is why new evidence came up in the last 2 years. This was the first of the network meta-analysis published in 2019 by Dr. Barrionuevo et al. On behalf of the Endocrine Society. And in this meta-analysis, again, the result for teriparatide with respect to hip fracture risk was a nice reduction in the risk, but once again, the interval was overlapping the neutral effect line, and therefore there was no significant effect in terms of reductions of hip fracture. This meta-analysis had a couple of characteristics, was restricted to postmenopausal women, and the trials that were included did not took into account some recent published result on the drug. And the same year, we ran another meta-analysis, a more classical meta-analysis using individual patient data that was published. And in that meta-analysis, we analyzed the effect on the hip risk of fracture. The methods of that piece of work was the inclusion of randomized clinical trials with teriparatide with a duration between 6 and 24 months, and the approved doses and indications. And all the trials had to be controlled versus placebo or versus an active anti-osteoporotic drug. They had to have report on non-vertebral fractures. The way we performed the analysis were the classical one according to the PRISMA recommendations, with selection and extraction of the data by 2 independent authors. And we use the usual exclusion criteria in this kind of meta-analysis, like narrative reviews, observational studies, etc. We came up with the inclusion of 23 randomized controlled trials with data on 8,644 subjects, close to 3,900 treated with teriparatide, 1,600 more treated with placebo, and a little bit more than 3,000 treated with an active comparator. The mean age of the patients included in the analysis was 67 years, and they were 545 men in the analysis, 6.3% of the total sample, and 520 patients treated because of glucocorticoid-induced osteoporosis, again, about 6% of the total. The average treatment duration was 18 months with a range between 6 and 24 months. The design of the trials was double-blind all along the study in 8 of the trials, and open label in 12, and was mixed in the remaining with an early phase in double-blind fashion, followed by an open period up to 18 to 24 months, 3 trials in this category. The comparators were 4 in against placebo, and 19 compared with at least one active drug. This is the table with the characteristic of the trials. Indeed, it's a very busy table, and for make your life a little bit easier, here is the summary of the number of patients in the trials that range for 2,400 to 44, and the comparators that were in 6 cases risedronate, in 4 trials alendronate, in 2 zoledronic acid, in 2 denosumab, 2 against calcitonin, 2 comparing with Romo, 1 against strontium and 1 against abaloparatide. And in 6 cases, the comparator was only placebo. And this is the summary of the results. This is the forest plot of the meta-analysis. And in this, we see that the summary effect or the overall effect show an odds ratio of 0.44 with a confidence interval that was statistically significant. And this is the number of teriparatide events and the number of control events. And indeed, what we were able to see in this case was a significant, statistically significant reduction in the risk of hip fractures. What were the main what were the main strengths of this analysis? We think that we ran a comprehensive systematic reviews of randomized controlled trials with active comparators or placebo in the control group at the approved dose and indications. And this was also the first systematic analysis at the individual fracture sites of the upper limb, by the way, showing no increase in the risk of forearm fractures like has been speculated sometimes. But there were also limitations. The number of hip fractures was rather small, 34, although there are other cases where the hip fracture effect relies on a similar number of fractures. We included men and patients on glucocorticoids where fracture risk for hip fractures might be different. At this respect, we ran a sensitivity analysis excluding men and excluding patients on glucocorticoids, and the results stand exactly the same. And the review of other fracture sites was not feasible because of the incomplete reporting for these other sites in some of the trials. After that, there was a couple of meta-analyses that were published last year. This was the first one published for the National Institute for Health Research and Health Technology Assessment of the United Kingdom. Was again a network net analysis. And this meta-analysis also demonstrated a reduction in the hazard ratio for hip fracture for teriparatide that was showing the most significant effect. And again, the confidence interval did not overlap the unit. In other words, the results were statistically significant with a 65 reduction in the risk of hip fracture. And the second one was this one that was published in the Health Technology Assessment Journal for NICE, again, a UK body. And in a similar fashion, in this meta-analysis, teriparatide demonstrated a significant reduction in the risk of hip fracture, or of almost exactly the same order of magnitude. Then if we go back to the clinics, the question is when to use teriparatide. And to me, a quite good recommendation was the published by the Endocrine Society, published 2 years ago in JCEM and updated last year. And in that guideline, the recommendation was the use of teriparatide as well as abaloparatide in postmenopausal women with osteoporosis at very high risk of fracture, and also remarkably recommending that after completing the course, clinicians should continue the treatment with anti-resorptive anti-osteoporosis drugs. And what is meant by high risk, imminent risk? If we try to put together several guidelines and recommendations published last year, we can say that a patient at high risk or very high risk or imminent risk is a case where one or more of these conditions is present. Fracture within the past 12 months, or multiple fractures, or a fracture that occurs while on treatment for osteoporosis or while on a medication that is potentially harmful for bone. In individuals with very low T-score, below -3, or with a FRAX probability over 30% for major osteoporosis fracture and more than 4.5% for hip fracture. Therefore, my conclusions after this short review is that teriparatide is a potent anabolic drug that improves bone mass quality and strength, and is very probably a first-line option in high-risk patients, and also decreases the risk of hip fracture, and always must be followed by an anti-resorptive. With this picture of what we see from my hospital, that is right by the beach in the Mediterranean coastline, I would like to thank you all for your attention, and again, Bone Echo for inviting me today. Thank you very much.
Okay, thank you, Adolfo. Very nice review of a subject that's often confusing. Mike Bolognese has some questions. You want to go ahead, Mike?
Just 3 quick questions. One is, you know, we did use the 40 microgram dose at one time. And when you do a comparison with abloparatide, I always wonder if we use a 40 microgram dose, if we get even better results. And then I had 2 other, since we have the removal.
Yeah, the first one.
Yeah.
The first one, very quickly, we only include the results referring to the approved dosing, 20 micrograms.
Okay, and now that
in this trial also.
Since we now have removal of the black box, how do you think that's going to impact the recommendations?
Well, this is the usual first question that a clinician must wonder, is that if there is some contraindication. Well, the black box for teriparatide comes basically from the risk of having had a tumor, and in particular any radiation for anti-cancer treatment, and also the age, younger age, before the closure of the growth epiphysis, and also in cases of hyperparathyroidism of end-stage renal failure. I am not aware at this point of any other, but indeed this is something we have to take into account very carefully.
Okay, thank you. Good presentation.
Okay,
thank you.
Kelly, why don't you go ahead?
Yeah, thanks, Adolfo. That was really nice, and your contributions as well as your summary of all the data was superb. This was a question that was on my shoulders for over 10 years, and I used to just cringe when somebody would be up at the podium and say, "Well, teriparatide doesn't work at the hip," and the correct response at that time was there was not enough evidence for the company to claim that it reduced hip fractures. It's still, as you point out, it's good. It's not perfect, but I have never thought there's any reason why it wouldn't reduce hip fractures. But yours and others, I think after 20 years, I think we can have confidence that it probably does reduce hip fractures. But I'm sure folks on the line will have different opinions, but I've always believed that teriparatide was likely to reduce hip fractures.
A short comment: if we had the perfect drug, we will not be here discussing anything, that's for sure. And the other point I refer to is that one of the problems with teriparatide with respect to hip fracture was the short duration of the treatment is only 2 years, while for most of the other drugs we have 3 to 5 years in most of the cases. And also the low rate and therefore the low incidence of hip fracture events in the trial. So it has been an endemic problem of lack of statistical power. This is when meta-analysis can help the clinicians, because beyond the observational studies and beyond all the preclinical and experimental data showing that very likely teriparatide is effective in reducing the risk of hip fractures, we need a clinical demonstration based on clinical trials. And this is the point where meta-analysis can help. And my opinion, after all what I have been discussing today, is that it does, that teriparatide reduces the risk of hip fracture, and it's a big help in our armamentarium for patients at very high risk.
Okay, thank you. Yev has a question.
Thank you so much for fantastic presentation. I have a question. I'm currently rounding in the hospital, and we saw a patient today with unfortunately recurrent Cushing disease. The patient failed everything, 2 times surgery, radiation therapy, all of medication options. So the patient will have most likely adrenalectomy in the future. But he was admitted for multiple vertebral fractures. He is 20 years old. He has been having Cushing for 10 years, 12 years already. So, and he was admitted for spinal fusion that was canceled because of DEXA scan results and terrible vitamin D level, like 10. So my question, would you use Forteo in this patient to bring his bone mineral density up before spinal fusion? Or would you use bisphosphonates first in this situation?
Well, if I correctly understood, this patient is 20 years old, is that right?
Yes. Yes.
Okay, the short answer is I don't know. And I am not sure that teriparatide could be a good idea for such a young patient in this indication. My first gut feeling will be to rule out any underlying diagnosis, osteogenesis imperfecta, any other genetic disorder, or some secondary cause of osteoporosis. And you say that the vitamin D levels are extremely low in this case. Probably will be helpful to normalize the vitamin D in this individual. But the use of drugs in these cases probably relies more in bisphosphonates. That is when we have more experience in this age period.
Thanks, Adolfo. Now that's an interesting question. I'd like to open that up for comments from other people.
Sure. Please help me.
Yeah, let's help each other. So 20 years old, very high risk of fracture. Would you feel comfortable with teriparatide in this man or not?
Mike, it's Elliot. I'm on the phone today.
Yes.
I would say, I think in the SAG GIOP study, the age group went down to 18. So I would feel perfectly comfortable giving this patient 2 or more years of teriparatide.
Dr. Schwartz, even in the situation, he still has active Cushing?
Yeah, well, you're going to do an adrenalectomy at some point.
Yes,
but
exactly.
We treat people, lupus patients are taking 100 milligrams of prednisone. We treat them.
Mm-hmm. Mm-hmm.
So I would say get his vitamin D level up as fast as possible. Make sure his calcium level is fine. Send off a genetic test, as Dr. Diaz-Perez said. That's going to take 6 to 8 weeks to come back. In the meanwhile, what are you going to do? Sit on your hands? Going to start teriparatide. And this would be a candidate. I don't know who else is on the call, but Paul, Mike, Kelly, and I just submitted an article on using teriparatide for more than 2 years, and this would be a patient at very high risk that I would consider as an
Yeah, this is Mike McCullough.
example.
I'd concur with that, feeling comfortable using teriparatide, particularly because he is active Cushing's based on the glucocorticoid studies of Ken Sack demonstrating superiority of teriparatide over alendronate in reducing fracture risk in those patients. And to treat him for 18 months to 2 years, then have him be on a bisphosphonate, and then, depending upon his future course, consider another course of teriparatide. The concern about teriparatide in young people, of course, is the theoretical risk of osteosarcoma when epiphyses are not closed. But if he's 30, that shouldn't be an issue in him. So
Now he's 20, so there may be a question about open epiphyses. Should he be checked for, should he have hand x-rays for bone age before
This is
starting?
exactly what concerned me, the age of the patient, because although it's more theoretical than demonstrated, but there is always a potential risk of inducing an osteosarcoma.
Now, there certainly are studies using PTH products in adolescents with hypoparathyroidism. And as far as we know, there's been no issues with bone growth and certainly no issues with osteosarcoma. So, you know, there is some evidence that it might be safe, even if the epiphyses are open, but it raises a little bit of uncertainty. Anybody else have comments on that? We have a few votes for teriparatide, some caution about using teriparatide. Billy, what would you do?
Well, I think the concern about osteosarcoma, I think we all have some comfort. It's less than it was 15 years ago, but I personally I do see some young people and I do make sure their epiphyses are closed. But especially if he's going to have ongoing Cushing's for a little while, I mean, I agree with Mike. We have fantastic evidence that teriparatide is the antidote for excessive steroids.
Yeah.
Okay, there you have it, Yev.
Thank you so much.
You can let us know later what happens with this patient.
Thank you.
Okay, let's see. Gabriella has a question.
Hello, I would like to ask if you would use parathyroid, if you would use teriparatide or abaloparatide in patients who had radiation, but local radiation to breast, not to the bone. So